This week on Primary Care, we're here at Plymouth United Church of Christ in Detroit, where I talk with Dr. Crystal Martin about kidney disease and why African Americans are at such high risk.
One, screening. We're lacking in screening. We're lacking in screening because they're scared.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health and care of African Americans. African Americans are at increased risk for chronic kidney disease, and most don't even know they have it. In the United States, African Americans represent 35% of patients receiving kidney dialysis, yet they are only 13% of the population. Why is there so much renal failure among African Americans, and why are they at higher risk? Here today to help answer some of these questions is Dr. Crystal Gardner-Martin. Dr. Martin is a board-certified nephrologist and internal medicine physician at Hypertension Nephrology Associates here in the metropolitan Detroit area. She is passionate about improving medical care in the Detroit area and has a heart for the community. She joins us today to talk about the growing epidemic of kidney disease and how we might fight against it. Dr. Martin, thank you so much for joining us.
No, thank you for having me.
You know, this is not a new problem. This is something that we as physicians and the community and patients have been struggling with for a long time, but it's changing. It's getting worse. Help us understand why we are losing this battle.
Well, a lot of it has to do with healthcare disparities, literacy, making sure that we have chronic kidney disease awareness in the community. A lot of people don't understand chronic kidney disease, and so ignorance is bliss. If I don't understand it, I don't really want to know about it, then I don't have to worry about it, which is not what's going on in our community especially. So in the Black community, we have a lot of high blood pressure, we have a lot of diabetes, and with hypertension and diabetes comes chronic kidney disease. We have an excessive amount of obesity. In Black patients, about 72% of our Black males over the age of 20 are obese.
Obese, that's correct.
82% of our Black females are either overweight or obese, which puts them 20-year risk, 20% will have chronic kidney disease. So that means if you have an obese child, you know that about 12, maybe at 32, they're starting to have chronic kidney disease or will be diagnosed with chronic kidney disease. So obesity, which has gotten worse in our community, is a big factor.
And the progressive nature of chronic kidney disease is such that, well, it doesn't hurt. So, you know, I don't have to bother with it very much. And, I don't want to hear any bad news from the doctor, so I shy away from it. We still struggle with those kinds of communicative processes in a community like this that this does not quite get the message through.
Exactly, and that's where we have to engage our patients or the community in these CKD awareness projects. We also have to engage with our primary care physicians to get them to understand. You have to help the patient understand. There was a study, 466 primary care physicians' offices, they did an observational multi-centered study on the patients who have diabetes, and in those practices, how many of them have chronic kidney disease? And when they looked, they said, even from stage 1, which is basically some mild abnormalities in the kidneys, versus stage 5, which is they need to be on dialysis, only 12% were diagnosed as having chronic kidney disease by their primary care physician. And as you said, so we have 32.6 million diabetics in this country, and 40% of them have chronic kidney disease, but only 10% are aware that they have chronic kidney disease. And Blacks, Indigenous patients, people, as well as Hispanics are at the highest risk. So they're the ones that we know the risk factors. We should be looking and talking to them. Whether they get evaluated and they don't have it at that time, we know they're high risk. So we want to make sure we're hitting our goals from high blood pressure, diabetes, control, and monitoring their urine albumin and creatinine ratio.
Chris, if this was a banking investment account, we would be sitting on the sidelines very happy with the growth of that particular account.
Right.
But we're doing that in a disease state that we know well, okay? Of course, we've got new things, and we'll get to that in a little bit, but we're looking at this from the standpoint of view, just waiting for the disaster to happen. Is that what you're saying?
Yes, and that's the sad part, is that this is a preventable disease.
Yes.
So one of the things when I did my internal medicine residency, I loved it because I saw all the prevention, but I really fell in love with nephrology. Why? Because the two top causes of kidney disease and dialysis are the two most preventable.
Right, right.
Diabetes and hypertension. So if we really educate, and one of the things I pride myself on, and I really have a passion towards, is I can educate the patients on these goals and the expectations. The expectations they should have from their primary care physician.
Exactly.
That physician inertia or medical inertia, right?
Right.
So the physician's like, oh, your blood pressure is 150/80. Well, it's better than it was last time. Let's see in 3 months if it's any better.
Right.
No medications,
Right.
no changes whatsoever, because they're worried that the patient's going to be mad or feel like they're failing their patient when they have to add another medication. Or we say, okay, we're already on 3 medications. I know this medication can protect your kidneys and prevent dialysis, but I don't know if I want to give you another med just yet or introduce that because you may get mad. But if we know that's what they need, we should be talking to them and helping them understand where they're even asking us, because they don't want dialysis. We know that.
Absolutely. My job is to be your doctor first, not your friend.
Exactly,
Right,
exactly.
Right. But here again, 2022, we're still suffering through some of the mundane things like testing. Primary care settings for testing for renal insufficiency or old term, or CKD, new chronic kidney disease, in the various stages. Walk us through that quickly here to talk about where people are at if they fall in the spectrum of chronic kidney disease. What are the stages?
Okay, so there's 5 stages of chronic kidney disease. So we're talking about chronic kidney disease, we're talking about irreversible damage that has occurred over time, right? Because a lot of people say, oh, was it both my kidneys? Oh, well, that was, that you said I had some chronic kidney disease, but is it better now? And a lot of times we're talking about things that are it's over time, it's a progression. And when you get diagnosed with chronic kidney disease, that irreversible damage can continue to worsen to the point where you go on to dialysis. So the 5 stages, we used to look at just the stage of kidney disease. So stage 1, kidney function is greater than 90%, or what we call estimated glomerular filtration rate. But we'll just, for simplicity, we'll talk about percentage of kidney function. And we define that, 1, if they have some abnormality in their kidneys on ultrasound or in the urine, some blood in the urine protein. But those patients typically do pretty well. Stage 2 is between 60% and 89%. And those patients, again, if there's no protein in the urine, those patients do pretty well. Stage 3.
Just to interrupt you, those patients, though, to me represent the first sign, the first signal. Go ahead.
And that is that's where the primary care physician is supposed to recognize that, and you start looking at, okay, well, do I have you on any non-steroidals like ibuprofen, et cetera, that may be affecting this? Is this a medication issue, or is this a sign that something else is going on that I need to jump on? Do I get an ultrasound or something? Stage 3, they're broken into 2 segments of stage 3. And that is because of what can happen at the different levels. What's your higher risk? So there's stage 3A, which is between 45% kidney function and 59%. And those patients are already right there at moderate risk of going on to dialysis just by being at 3A. Then 3B is between 30% and the 44%. And those have a higher risk. They're at high risk for chronic kidney, for going on to dialysis. Then stage 4 is between 15 and 20% kidney function, and 15 and 30%. And those patients, again, already at severely high risk. At that point, I'm starting to talk to them about transplant. I'm starting to say, hey, let's be preemptive in getting you evaluated, because I'm probably not going to make a difference. I'm still going to do everything, because if I get you transplant listed, they can't list you till you're less than 30. So if they're less than 20% kidney function. So if I can get them around 25 and they look like they're high risk, I'll get them evaluated. They said, we can't list you 20. The minute they hit less than 20, we get them on the list. I still put them on medications to try to prolong the progression, to keep it from progressing, so that they get time served on the list before they even see a dialysis machine. I've had a couple of successes where my patient never saw a dialysis machine. They got straight to a transplant and kept on with life.
Well, we have a professor at U of M who was on the show a couple of years ago, who basically hit below 20 in terms of his estimated GFR, and became a strict vegetarian, vegan, one of those choices. And he has held so steady, it's unbelievable that there's been no progression. I mean, it's like there are some instances where these numbers are treatable, okay? But the reason I asked you to talk about the stages is because we have been drilling numbers into patients' heads. Know your blood pressure, know your cholesterol, know your A1C,
Right.
those kinds of things. I think we're on the cusp here of saying, look, you need to know what stage of your renal situation is. That's going to be very important going forward.
And they need to know their UACR, their urine albumin creatinine ratio. So less than 15% is around the time you may need dialysis, you're starting to have significant symptoms. So definitely around then we're knowing you're going to probably need to start dialysis very soon.
Which with proper treatment, the urine gets better also.
Exactly. So the urine albumin creatinine ratios now is also a requirement for evaluation. So if their urine albumin is 0 to 30, those patients do pretty good. Less than 30 milligrams, you have low risk. But in conjunction with what stage you're in, 30 to 300, those patients have a moderate risk of going on, and greater than 300, you have a high risk. But there's medications to treat because that urine albumin creatinine ratio is a sign of inflammation that's going on in the body, right? So what you're talking about, which is most important, is when we talk about diet. I always concentrate on diet with my patients. They've recently talked about plant-based protein. Remember in chronic kidney disease, we say you have to start restricting your protein to save your kidneys. Right. And people are like, okay, I'm starving, I'm not eating, especially if you're losing a lot of protein in the urine. But protein that's plant-based is not restricted. Right. And you have less inflammation, right, and that is happening with plant-based versus the animal-based protein. So that can make a huge difference in your diet.
Huge difference. That's why it works. Talk briefly about symptoms and why it eludes a lot of us in the discussion.
I always say chronic kidney disease is like hypertension, the silent killer. By the time you feel it, it's too late, right? That's why screening is so important. Mm-hmm. That's why awareness, so you know what to ask your doctors. I show my patients the KDIGO heat map, which puts that yellow, the green, yellow, orange, red based on
they're stopping at red lights all day. They know they could
right.
They
know that. That's what makes it simple. It's visual. We need to have more visual assistance for our patients in our offices so they get it. So when you show them this and you say, okay, this is where we are based on your urine albumin, you're at high risk. Then when they come back, we show them on the heat map, hey, these medications brought your protein down and your kidney functions better, so you're doing better. And they start realizing, but that red, yellow versus green, that really hits, and they understand I have chronic kidney disease.
Dr. Martin, we're up against a quick break, but we're going to return in just a few minutes here with Dr. Crystal Martin, nephrologist and hypertension specialist.
Hello, I'm Pastor Nick Hood, the third pastor of the Plymouth United Church of Christ, located in the heart of Detroit, as I like to say, the tip-top of the medical center area of Detroit. I want to thank Dr. Lonnie Joe for the opportunity to say a few words about healthcare and the role of the church with healthcare. At my church, we're blessed to have a number of physicians who are members of the church, many of whom are with the DMC, and very often we call on them to share health news and health awareness for the congregation because in the African American community, we experience some of the worst cases of health care in terms of diabetes, mental health, heart disease, cancer. And as a pastor in the heart of Detroit, I think it would be a crime not to take advantage of the know-how of the doctors. I want to thank Dr. Lonnie Joe for giving me an opportunity to just say a word. I have immense respect for Dr. Joe, and I hope that together we can make for better health care in this community. God bless and God keep you.
We're here with Dr. Crystal Martin, nephrologist and hypertension specialist, talking about chronic kidney disease in African Americans. Dr. Martin, why is it that African Americans are showing up so late? We're presenting in the late stages of this disease. We know there are multiple factors, but help us understand why this trend continues.
Okay. Well, one, screening. We're lacking in screening. We're lacking in screening because they're scared, right? They're not showing up to a lot of these health fairs to learn about chronic kidney disease. They don't know the right questions to ask their primary care physicians, but also, unfortunately, our primary care physicians are sometimes failing our patients.
We have a role also.
You have a huge role.
Huge role.
Because they then started, they made sure that when you get the lab work back, it says these are the stages. Oh, this patient has a estimated glomerular filtration rate or their kidney function is this amount, to try to alert the doctors like, hey, you need to talk about it. And guess what we say? Oh,
It's okay.
it's only mild. Oh, you only have a little bit of kidney disease. It's only mild. So the patient's like, great. Well, and then somebody asks them, oh, I don't really have any significant kidney disease. My doctor said I have a little bit. You know, if you actually really push them and ask. There was a study that showed for health service screening, when they were asking patients with chronic kidney disease, do you have kidney disease? You had to ask, has anybody told you had a kidney problem? No. Did anybody ever tell you had protein in the urine or something? Oh, well, maybe. Do you have kidney failure? You know, you had to put all three questions together before they finally say, oh, yes. But if you just said, oh, you have any history of kidney problems? No. And then they move on, so people weren't recognizing it.
But the alert of the abnormal stage of the GFR should be an indication and a kickback to other disease states like the hypertension, like the diabetes, like the abnormal lipids, like the obesity, to say, look, if we fine tune some of these things, all of those are part of preventing the progression of the kidney disease. So it's sort of like a focal point to be identified, especially as it relates to the overall care of the patient.
Right, because early identification. So first, we have to recognize as physicians their risk factors.
Right.
If you say, I have a family member that's on dialysis, my father, my uncle, my cousin, my sister, that means your risk is right there.
Right there.
So that's why we have to get the goal, not 140 over, less than 140 over 90. Your goal for blood pressure should be less than 130 over 80. And don't let it die. I always tell the patients, if your doctor says, know what your blood pressure is, and if they don't do something, say, no, Dr. Martin said that my blood pressure needs to be this to keep me off dialysis.
Right.
What are we going to do about it?
Right.
You know, but the issues are that we're not hitting those goals. We're not telling them how serious it is. And when they also had another study showing, looking at why aren't people coming for screening? Why aren't they attending health fairs? It was the perceived seriousness they didn't want to know. The perceived susceptibility. Am I really susceptible to this? I don't have high blood pressure. Just because you don't have high blood pressure doesn't mean you don't have kidney disease.
And that is so important, Chris. I mean, sometimes I feel like I've done 1,000 health fairs, but I don't think I've ever done a health fair where we didn't have to call an ambulance or, you know, tell somebody you need to see a doctor in 3 days for it. Here are the names of 3 physicians that will, you know, accept you next week to get in. We found abnormal blood sugars, abnormal blood pressures, peripheral disease just by observation alone and looking at extremities. I mean, the disease states are out there. Okay, our problem is basically making sure that we have direct connect to get people into the proper channels for care and treatment. And part of that is patient as well as physician education.
Exactly, and physician education. And unfortunately, especially in the Black community, the availability of high quality care, right? What's another thing that's getting us, and we're getting later stages, is we're not going because we have a distrust for the medical, you know, for medicine. And what the doctor is telling us, the financial burden, co-pays, patients, or even for their medications. Well, I don't feel it, so my blood pressure must be okay. I'm telling them, you need to check your blood pressure at home. Now we have these care models where you're supposed to incorporate everyone. I think as primary care physicians, you need to build a team, right? I have doctors that we have each other on speed dial. Oh, Mrs. Jones is in the clinic right now. You won't believe what her blood pressure is. And can you see her now? Can you see her tomorrow? Get them in right away, so they understand that's that physician inertia. You're saying the seriousness is, I need you to see Dr. Martin right away because, well, really, is it that bad? Yes, it is, because we're not trying to put you on dialysis. But if we're like, okay, well, here you see this one, we don't call the consultant, and they said, oh, your next appointment's in 3 months. They're waiting with blood pressure out of control for 3 months. They're a stroke waiting to happen for 3 months. They're having damage. And we need to do earlier. The earlier that we can diagnose, if we screen and recognize it, stay away from nonsteroidals. Let's really work on your diet. We have to really work on your blood sugars. I have to make sure when I find protein in the urine that I'm using all the right medications, because we can prevent the progression. We have new medications out here now.
We want to get to that. And since you landed on it, talk to us about some of the latest and the greatest. I mean, it is really exciting.
Latest and greatest. It's amazing. So at one point, the dialysis company came to my group like, hey, you know, you're having less people on dialysis. What's going on? Are you referring to our competitors or something? This was like 10 years after ACE and ARBs.
Okay.
The data on ACE inhibitors and angiotensin II receptor blockers came out.
Preventing renal disease.
Preventing renal disease. So people, again, we were slowing progression, but we weren't preventing it.
Right.
So instead of being on dialysis within 3 to 5 years, people were going more like 8 to 10, but they were still ending up on dialysis. And we've had nothing new since then. So about 10 to 15, about 20 years almost, we didn't have anything else to offer until now. So the data has come out more and more, and we're pushing more and more. Now we have what we call the SGLT2 inhibitors, the sodium glucose transporters, right? 2 inhibitors, where is showing that not only are we decreasing the protein in urine, which again, don't forget, protein in the urine is a sign of inflammation. It's not only inflammation in the kidneys, that's inflammation of your vessels, inflammation in the heart.
It's heart
vessels.
disease.
Heart disease.
Yes.
They're equivalent. The kidney and the heart act like best friends
right.
sometimes,
They
right?
hold hands.
Yes, they hold hands.
Right.
So when we start these medications, we're seeing decreased cardiac death. People aren't dying of MIs, they aren't having as many MIs. We're decreasing the incidence of heart failure, but we're also decreasing the progression
And some of the markers of inflammation when the insurance company lets you do
to
it.
pay it, right?
I mean, sure,
You know,
we can actually draw your blood and say, boy, your MPO, your myeloperoxidase is decreasing, and it's a real improvement in the inflammation. A sign of what's going on in your coronary vessels. I mean, it makes sense in the long run in terms of how the body is talking to each other from system to system. We just haven't been listening very well.
But we have, and see, that's the great thing about being a nephrologist, because we're the black box of the body. So we've always had to think of what's going on with the lungs, what's going on with the GI tract if they're having diarrhea, they're losing something, what would the kidney do if it's not acting right?
How does it respond?
How's it in the heart? We had to always think of the whole system. So we're always looking at that bigger picture. So I can't just treat somebody when they come in for high blood pressure or kidney disease. Well, what's going on with your arthritis?
Well, Chris, your passion comes through. We've known you for years, and it's always been there. I don't know but one way that you've presented these kinds of things. And when it comes to kidney disease, the passion has always been there. Where does that come from? I mean, on a personal note, where does that come from with you? Is there something behind this other than just getting excited in medical school about the subject matter, or what?
I'm going to tell you, I was born and raised in Detroit.
Okay.
And we took care of our people. Right. I mean, my play uncles and aunts were nurses and doctors, and I saw what they did, and they went that extra mile because everyone's like family. I teach residents and fellows, and I'm like, if you treat your patients like family, you'll never go wrong.
Never go wrong.
Because you're going to communicate with them, and you're going to always want what's best for them. My passion also comes from God, because he says, you do right, one day I want to be there, and he says, well done, my faithful servant.
Don't be messing with his, we're here at the United Church, don't be messing with his creation.
Right,
In other
and
words,
the thing is, I see where people end up on dialysis because the right things weren't being done in the forefront. They weren't being done at the beginning. So they come in and they're like, especially when I first started practicing, even now, you have chronic kidney disease. Why aren't you on an ACE or an ARB? Why aren't they using these newer medications on you? And we take it upon ourselves, even though they sound like they're diabetic medications, we know it's going to protect the kidney, we're starting them.
Here we're sitting in a church. What is the role of the church? I mean, it's hard to be raised in Detroit and not have church around your life somewhere. I mean, this is a church town. Okay?
Right.
What is the role of the church in terms of what we're talking about here? We're talking about a specific disease state that in just a few hours from now, people are going to be sitting in the pews with unidentified renal disease, chronic kidney disease in whatever stage, or probably going to find a few in renal failure, just haven't arrived yet to the emergency room. What is the role of the church in this approach?
I think that the church doesn't realize the huge role that they can play in awareness, identification, treatment, and decreasing the progression onto dialysis, because they're facilitators. Where patients have a distrust of their physicians, they have a trust of their church leaders. When they have screening, these are their friends that are in church that they trust. They're church leaders that they trust. They're in a friendly environment, God's home. So they come in here and they're able to let down their guard. Then, on top of it, they're hearing it, and then we're presenting that same message. Lastly, you have weekends. We're doing most of these things in somewhere that's close to them, their churches, and they're open on weekends and they're hearing about it. A lot of times my patients don't come to see their doctors because they have to take off work. Everything's during the week. So and also providing incentives, like, hey, we're going to have a yoga class, or hey, we're going to have a food giveaway, and we're going to talk about this. That brings them in, and we have to start utilizing our religious facilities to help bring that message to them, because they're not necessarily hearing it from their doctors the way they should. And this is the opportunity to screen and say, hey, this is where we're going to send you.
Patient education is so important in this whole scheme of things. If we don't find a way to educate patients in terms of their particular disease state, we're going to have some bigger issues, or we're going to have the same issues and not be satisfied with our outcomes. One last thing, and I want to drag this into the discussion. Recently, we lost the services of transplant abilities here at the medical center here in Detroit, and that's devastating to this community. I think people are so depressed behind it, they're afraid to speak about it. But here again, that is something that should not have happened, and should not be allowed to stand as it is now. What has this done to you in terms of your practice and your patient population, and in terms of outcomes? What does that landscape look like now that we don't have that availability out of the medical center? Now, granted, people can go elsewhere, but let's face it, we don't have safety net anything anymore. We don't even have safety net system anymore. It used to be safety net hospital.
Right.
Now so we're struggling with this in terms of trying to make this work. How has this affected what you do in the global sense?
Well, it's a tragedy, right? Because our patient in Detroit, DMC, was an iconic facility.
Yes.
Black patients would say, I can trust DMC because they care about me. They've been in the Black community for years, decades.
Remember when all the hospitals were leaving and going to the suburbs
Right.
20 years ago? And
Exactly.
we need to build in order to stay in business. Yeah.
We stayed.
Right.
And a lot of the patients trusted DMC, so when it came time to get evaluated for kidney transplant, they knew from being in and out the hospital, sometimes seeing the nephrologist there and the primary care physician, they trusted them. And the doctors that were there, the transplant doctors, they got to know, and they come in my dialysis unit, they come and they actually do a transplant month, right? But to get to the point, so for those patients, it goes back to the trust of the medical facilities and the medical profession. They felt abandoned, right? A lot of my patients didn't even find out that the transplant center was closed because somehow it wasn't advertised on TV. The news channels really didn't talk about it. How it wasn't front page news and on every news station that the iconic facility, DMC, closed their transplant program. Because 6 months later, I have patients still saying, because every time I go to dialysis, hey, how are you doing on the transplant list? So I'm listening, we're Harper. No, Harper closed. That closed 3 months ago. They weren't even getting in touch with the patients to let them know until after they had already closed, even though they knew they were having problems. And even then, not letting them know for months. That lack of respect, as I would call it, lack of respect for the patients, for the physicians, nephrologists. Luckily, because I was part of administration, I heard some of it, but I didn't hear it from administration. I heard it from doctors who knew me. I heard it from the transplant director who called me to say she was leaving.
And we heard it from patients.
And we heard it and some of them we heard just from patients.
Right. More to come on that issue. Chris, we will be here forever talking about these issues, because this is not only the science and the treatment and everything, but also the social issues are also very important. They go hand in hand. We can't separate them, and when we do, we fail. Thank you so much for being on the show. This has been an absolute pleasure.
Well, thank you for addressing this.
Excellent. Our guest has been nephrologist and internal medicine physician, Dr. Crystal Gardner-Martin. African Americans bear an undue burden from chronic kidney disease, and as we mentioned, most don't even know they have it. Increasing awareness and early detection are paramount to changing the trajectory of this growing epidemic. For Primary Care, I'm Dr. Lonnie Joe.